Okay, here we are in the last stretch of today. Thanks everybody again with the various time zones. Some of you have been on the screen all afternoon, some all evening, some morning and afternoon. So we're very appreciative of you guys staying with us. Okay, so the floor is open for any and all questions that you feel you need an answer for. If we don't have the right expert or the information, I'll say fill out the questionnaires, and we also can get your questions to the right experts if we don't have them here. So you can use the chat, you can raise your hand, you can just shout out. And you may be exhausted, and that's all. That's also fine. Wow, we might have covered it.
Sharon, Jouni here.
Yep.
There was I saw in a chat one question. It disappeared somewhere, but it asked if the mutation is classified as a VUS or variant of unknown significance. What does that mean?
Yep.
And basically, so there is a American College of Medical Genetics, geneticists classification, which kind of classifies mutations in 5 different categories. At one end are kind of changes in the DNA, which are very likely to be of no consequence. So they are called normal polymorphism. There are variabilities. Half of the people may have it, and obviously half of the people don't have the disease. So this doesn't mean anything. And the other end of the spectrum are pathogenic. And for example, those I mentioned, the nonsense mutations, stop codon, you don't make the protein, the full-length protein. So obviously that has consequences for the function of the protein and is therefore causing the disease. Now, in the middle is VUS, variants of unknown significance. So there is benign, likely benign, then variants of unknown significance, likely pathogenic, and pathogenic. And those variants of unknown significance, we cannot really decide, are they pathogenic based on the current kind of methodology that is suggested by the American College of Medical Genetics. There are some newer techniques or newer algorithms, newer kind of pipelines for interpretation, which can determine, is it more pathogenic or likely benign? But if you have 2 mutations, one is clearly pathogenic and the other one is in the VUS range, but most likely or leaning towards pathogenic, that then confirms the diagnosis. So there is some kind of improvement in the technologies coming online, and we are starting to use those new techniques. So there are hopefully less VUS, which is sort of ambiguity in the interpretation.
And Jouni, I'm going to follow on, not in order, because we'll just stay with this topic for a moment. If someone was tested for ABCC6 mutations, did that test likely look for ENPP1, SAMD9, and so on?
So about 90 to 95% of the PXE patients who have a classic form of PXE, they have ABCC6 mutations. But there may be in a smaller percentage other genes, in particular ENPP1, but they often have a little bit different kind of presentation, not very classic. They may have much earlier vascular involvement, for example, which sort of tips to the direction that maybe is another gene mutation or even perhaps a modifier gene that is involved. But what the techniques now are going is you don't look into single individual genes anymore. You don't target just ABCC6. You use whole exome sequence, which looks into all 20,000 genes that we have in our DNA. And that then picks up the mutations in all different candidate genes for calcification disorders.
Okay, I'm gonna add our other panelists to the panel. And some of these are pretty general questions. So one is secondary Raynaud's ever diagnosed with peripheral artery disease? And I know none of you are vascular specialists, but in your clinical opinion.
I would say no. I don't think that's a feature of peripheral, of obstructive or peripheral, atherosclerotic peripheral vascular disease.
Great. Next question. Is the elliptical the same as the treadmill? And then there were some other questions too about running outside or using a bike or swimming. So are we saying one specific thing for PXE, or are we saying all exercise is good?
I think all aerobic exercise is good. Obviously as things, the elliptical may be a bit easier on the knees and back than the treadmill, but a lot depends on personal preference and other musculoskeletal factors, what you can tolerate best. I wouldn't discourage it, or personally, I prefer the elliptical, especially with the television in front of it.
Right. All right. Symptoms due to, I think somebody needs to unmute to mute. Due to symptoms of perimenopause, it was recommended that she go on oral contraception, but she's learned that that is not wise for people with PXE. What do you recommend for your patients? So I can say what I've heard from vascular specialists, et cetera, is that I'm not sure where you heard it's not wise in general, and that one should work with one's own clinician around this. So for example, if you have severe arterial disease, then they probably would be suggesting something different. But if you don't, then, and they would weigh the pros and cons of the variety of symptoms you're having, then in fact, taking an oral contraceptive might be a good thing. I don't know if any of you have anything to add.
Yeah, the question was phrased in a way that said, well, what do you do for your own patients? And I don't really get to make that decision for my own patients. They don't usually consult us for that, especially my pediatric patients, which is most of what I see. But in general, I think the current recommendations regarding estrogen replacement for perimenopausal symptoms is that short-term, they should be used for short-term only, and they're generally contraindicated in those with other cardiovascular risk categories. If somebody has got clean arteries and no cardiac symptoms or signs, and it's probably fine for short-term. But I think in general, it would be discouraged except for severe symptoms.
How will PPI treatments treat various PXE-related symptoms?
Well, the PPI basically is the deficiency of PPI is the feature that allows calcification, mineral deposits to occur. And so if you raise the PPI levels to normal level, then you expect that there is no further calcification. So potentially it prevents deterioration of the disease. Whether it reverses, whether it removes any of the calcium deposits, that remains to be seen from the long-term clinical trials. There is a potential that some of the calcified tissues have a turnover. They need to be replaced at normal level, a normal situation. And if you have now normalized PPI levels, those new tissues are not calcified. But there is no specific clinical indication for PPI. It's a generalized inhibition of PXE consequences in terms of preventing calcification.
Right, and we don't really have any clinical studies on PXE and PPI yet, aside from knowing that it increases PPI in the blood, but wouldn't mitigated any of the symptoms or signs. If we're taking anti-VEGF and it's working well, is there risk of other eye or macular degeneration over time?
Well, we discussed the fact that the second eye, the fellow eye, does have a risk. It can vary from 20 to 40% over a 5-year period, depending upon certain features that we see. For example, a reticular pigmentary change seems to increase that risk. And therefore, we monitor the other eye at visits, and the patient should monitor the fellow eye at home. One thing I failed to mention, I think it was a question that was posed in terms of risks, not really a risk, but a lot of people complain. And Sharon, you mentioned that I should talk about this, the discomfort associated with the injections. And of course, that doesn't depend on the medication used. It's usually related to the betadine that we use to prevent infection. And so there are just different things you could ask. If you're experiencing pain, several hours after the anesthesia wears off, you can have the physician wash out the betadine afterwards, because it's basically done its job. It's put in to reduce the bacterial count before the shot. Different types of anesthesia, whether it's topical or an injection, subconjunctival, some people experience different levels of discomfort afterwards. So there are a couple of things. Or the iodine could be applied just to the quadrant where the needle is going to go, rather than bathing the entire eye with iodine. Yep. So basically, we have used antibiotic drops in people that claim to have an allergy to iodine, or we can use chlorhexidine as a substitute. So there are many. Just speak to your physician if you find it particularly uncomfortable, and they can try any of these variations of the theme to try to make it more tolerable.
Great, thanks. So the question is, I was diagnosed more than 40 years ago via biopsy and never had DNA testing. Am I correct that I should do that now? Also, I assume my sons are carriers and that my grandchildren could also be carriers. Should they be tested so they are armed with that knowledge? How do I go about doing that? I'm going to caveat this answer by saying, because I work with Genetic Alliance on 7,000 diseases, that everyone carries somewhere between 7 and 20 different mutations that are carriers. And so I often say to people who ask me this question, there are much more common rare diseases like cystic fibrosis, and in certain populations, some other things like Tay-Sachs and sickle cell. So if you're going to be interested in carrier screening, you probably want it to be pretty broad, because PXE is pretty rare, although of course you and your children are carriers. So go ahead, Jouni or Lionel, Wayne.
Yeah, so Shannon from Missouri sounds like has a PXE, which is biopsy proven. So, and you say, I'm sure my sons are carriers. That's not necessarily true. Statistically, they have 25% of having no mutations at all.
Oops, you muted yourself. And Jouni, if she's affected, then her sons are carriers, obligate carriers. Is that right?
Yeah, so if I read this right, so yes, the sons are carriers. Yes.
Yeah.
And okay, and they can be tested for the carrier status. Depends how old they are, whether it has any clinical implications or not. But yes, that can be tested. And then, of course, my grandchildren could also be carriers. That's correct too, but there is a smaller percentage. So it comes to the issue what the carrier knowledge really is, and that's what Sharon is saying. There are lots of carrier diseases. As I said, in the United States, there is 150,000 people who are carriers for the PXE gene mutation. So it should be a more kind of broader carrier testing program available.
Yeah, that's a very rare. The other thing is carriers do not have any clinical manifestation of PXE. And so again, the usefulness of that information is to be debated. And in a heavily burdened healthcare system, I have to say this from a public health perspective, just because we can do something, we shouldn't just be doing it. And so again, if somebody's thinking about having children and wants carrier screening broadly, then that's certainly very, very available in the US. And you go about it by asking the gynecologist or obstetrician to do it. And they will also do the father of the child as well as the mother.
I should add, it might be difficult to get insurance coverage for carrier screening for an asymptomatic child when because it's not going to affect management anyway.
Right. Yep. It'll be out of pocket.
Yeah, I should add though that the carrier testing or even the kind of general whole exome sequencing, that the cost has gone down.
Come way down. Yeah.
When the first human genome was sequenced, that cost about how many $1 million, Sharon?
Almost $1 billion for the first one.
Almost $1 billion, and now you get with a couple of $1,000 the entire genome of any individual done.
Yep. So if you have some money to burn, you can get carrier testing for about 150 diseases for $100, which is very cheap. If you want to do a whole exome, those are somewhere around $400 or $500, and a whole genome's around $800 to $1,000. As those who do this work will say, and the interpretation is $1 million because it costs quite a lot to look at all that data. Okay, next question. I was diagnosed with GAVE or GAVE or watermelon stomach. Is this related to PXE? I've never heard of that. So I can't.
It's gastric antral vascular ectasia. That's what it stands for. I'd never heard the term watermelon stomach. I mean, watermelon stomach is what I have all summer because I love watermelon. I eat it. So yeah, I don't know. That's a very interesting question. You know, the question is it really gastric antral vascular ectasia or is it PXE? What happens in this condition is there is dilation of the I presume are arterial vessels, but I'm not sure what kind of vessels they are in the gastric antrum, and they bleed easily. It's one of the causes. It's an uncommon cause of GI bleeding. Maybe, you know, in this patient it is PXE. Maybe it is actually PXE changes presenting as gastric antral vascular ectasia. I don't know. That's a very good question.
Those calcified, those vessels, Lionel.
Yeah. So I mean, I don't know. I think it would be I mean, the academic in me wants to write it up as a case report and publish it, but I don't know whether I think it's possible with you know, magnetic resonance imaging. It may be possible to tell if the vessels are calcified or not, and you may be able to make more of an educated guess. It also depends on when these were diagnosed. If they were diagnosed, you know, in somebody's adolescence or early 20s, I say maybe it is a different condition. But it's quite possible somebody who's never really seen vascular changes of PXE in the stomach might see these changes and refer to them as GAVE, or, you know, that's a good question. I don't know the answer. I don't think I think it might be possible looking at the gastroscopy images and talking to the gastroenterologist and putting the whole thing in clinical context to come up with a more intelligent statement, but it's food for thought.
And it's certainly something we can easily add to the survey so that we can find out, you know, how we've done this in the past is we got women who had problems with their mammograms and then looked at hundreds of them. The same thing with testicular microlithiasis. We got a couple of boys, in fact, who had this problem and then got dozens of them, not hundreds in this case.
We have to find people who've had upper gastrointestinal endoscopies and find out if any of them have had this diagnosis, or look at images and see what we come up with. We'd have to look at this. This would have to be the index case and look at the images and see what they actually look like.
Yep, great. Okay, is there a link between PXE and Ehlers-Danlos?
Different kinds of diseases. There is no calcification in the Ehlers-Danlos syndrome. There are vascular issues, in particular the vascular type of Ehlers-Danlos syndrome, but they are completely different issues. So there is no, usually there is no diagnostic ambiguity between these two conditions.
Right, and we have people, right, and we have people with both. The Ehlers-Danlos registry tells me I have a couple people with PXE and I have a couple people with Ehlers-Danlos. So again, unfortunately, we can all have more than one disease. It's not fair, but it happens, even rare ones. I'm going to answer the registry questions last. So anything else for our experts? Okay. Oh, with shockwave, oh, this might be a difficult one because I don't think Scott's here anymore. With the shockwave lithotripsy, is there danger of pieces of calcium plaque breaking off and causing blockages elsewhere that might be more serious problems, cause more serious problems, for example, a stroke? These guys are not going to take a shot at that. Questions we can't answer here, we will get you the answers. We get to save this chat so we can. I
mean, this happens in atherosclerotic disease where either small platelet emboli end up producing mini strokes or TIAs or pieces of plaque. But I ulcerated plaque. But I don't know that the calcification here is generally pretty. It's not really that superficial, but I don't know the answer to this. I don't know if anybody's actually looked at you'd actually want to find a piece of what embolized and see if it's calcific or not.
Isn't the lithotripsy sort of, it pulverizes the calcium deposits, so it's unlikely that you get larger plaques going.
Well, lithotripsies are really in the urinary tract. I mean, it's not in the.
That's right. Yeah.
So it would have a very circuitous route to get to the brain. But I mean, you do see ulcerated atheromatous plaques will embolize, but I don't know that these plaques characteristically ulcerate or do this.
Next question, I sort of don't even want to read because I hate when our old non-scientific things appear again. But the question is, a long time ago, taking a calcium supplement was discouraged and thought to be bad for PXE patients. But PXE, I think PXE International later found this not to be true. So would you say something about restricting dietary calcium and taking a supplement?
Well, I can only say that early on when we developed the PXE mice, we one of the first studies we did, we fed them with massive amounts of calcium, and nothing happened to their degree of calcification. So low and high calcium diet gave the same kind of clinical presentation. Now, of course, mice are not people, so they may be different, but in humans, calcium plasma levels are very well controlled by hormonal parathyroid hormones, etc. And even the plasma levels do not change to the pathologic if you have calcium-rich diets, so unlikely to have anything to do with PXE.
And Jim, I think the panel understood that you're talking about shockwave lithotripsy for peripheral artery disease, not kidney stones, but they were commenting that they only knew about kidney stones. So we'll talk to Scott about that. Okay, anything else?
Lithotripsy, I mean, by definition means breaking up of stones. That's what lithiasis means. I don't know what issue lithotripsy for. I think well, you certainly can do balloon angioplasty to break up plaque. That's been done.
So Lionel, you missed Scott's talk, but he talked about, and there is a new way to treat some of the mineralization in arteries by doing lithotripsy.
Oh, so same technique using high intensity ultrasound.
Yes.
Yeah. Okay.
Yep. Yeah. So what you said applies. It's just it wasn't specific, and I was just mentioning to Jim that you were extrapolating from your experience, but we'll get that question to Scott.
Yeah.
Cool. Anything else?
I guess if that technique is employed on for vessels in the lower extremities, it's unlikely they would get back to the pulmonary circulation. Get back to the left ventricle and be pumped back into the cerebral circulation. I mean, there would have to be you'd have to have either a patent foramen ovale, connection between the left and right sides of the heart, or otherwise, I think that would be anatomically very difficult to happen.
Patrick Hanley, can you unmute so that you can ask your question aloud, since typing is hard? I don't know if you're able to unmute.
Okay, can you hear me now?
Yes.
Yeah, does this have any effects on the capillaries? I mean, as far as you got your arteries and veins, but does it affect the capillaries in any way?
It's an arterial disease, and basically what happens with the calcium, it binds to all tissues that are rich in elastin, and therefore certain tissues, we get, for example, calcification in the lungs, but you do not get any significant clinical implications. So you get skin, which has the elastic fibers. Calcium binds the elastic fibers in the dermis. You get the eye problem because you have the calcium-rich sheath, the Fuchs membrane, and then you get the arterial blood vessels, which are rich in elastin, but the venous side does not get calcified, and the arterioles, the kind of between, I don't think, Lionel, correct me, but I don't think the small ones get calcified.
No, we actually did I'm trying to remember when it was about over 20 years ago, 25 years ago, we did we had some autopsy material donated, and we had examined tissue in several organs, and there was minimal, I mean, almost no involvement of veins. We found some ultrastructural evidence of calcium, and nothing in the capillaries. I don't think we even found anything in the lungs except in the vessels in the lungs. And there was a little bit in the testes, but really most of it was vascular. No, nothing in the right capillaries at all.
Okay, yeah, I just never heard it mentioned, but I've got issues in the feet and the ankles. I didn't know if it went that far as in the capillaries.
No, now, I mean, Wayne can tell you that in the eye, you'll get angiogenesis of capillary-like vessels through the brake and Fuchs membrane, but the vessels themselves are not specifically affected by PXE.
Okay, thank you.
I would agree with that. And with respect to what Lionel was saying with lithotripsy and the vessels, his basic point was that if you break up the calcium, even if a small particle were to head downstream, it would end actually in a small bifurcation or capillary. It would never come back in the venous circulation, causing a stroke or heart attack. But we do see complications from vascular procedures, like when people have the TAVR to replace the aortic valve, there is an increased risk of stroke from that procedure because you're in the arterial circulation there near the heart. And if a particle breaks off, it can go to the brain. But in the lower leg, it can't really go to the brain. It always goes further downstream. And so we wouldn't expect any, and besides which it's pulverized, as was pointed out by Jouni. So I wouldn't expect any problems, but I guess you're going to have that question answered by the vascular people.
Mm-hmm.
Okay, yeah.
Right. Thanks, Patrick. Another question, I'll be having a cath in a few weeks. Anything I should make sure of to make sure the doctor's aware of due to PXE?
Cardiac cath?
A coronary cath?
Yeah, heart catheterization, yep.
I mean, I think we all recall one publication where a patient didn't know they had PXE, with some sisters had PXE, and they reflected a thoracic artery, the internal mammary artery, instead of using the saphenous vein. And that was a mistake in PXE, because you would want to use a vein if it came to a revascularization procedure. Most people don't have that these days. They're usually stents, but make sure not to use the internal mammary artery to bypass any vessels.
Well, that would actually be open heart surgery. I think they're just referring to the catheter. So the most they might have would be a stent, I think.
Right.
I assume the cath is for coronary angiography and not for a valve. It's for a valvular problem.
Sharon, may I ask a question? I'm sorry, I'm so technically challenged that I've been trying to send something under chat, but it's not reaching.
Okay, yes, and I think it's Hope. I can't see everybody.
It is,
Yeah.
it's me. Yeah, thank you.
Okay,
Thank you very much. My doctor, cardiologist, suggested I should stop taking edoxaban, which another specialist cardiologist had prescribed, and he attributed his advice to my having PXE. That was the first question. The second is, I saw a large arrow pointing to statins on the slide that was dealing with deficiency in PPI. I wasn't able to be here earlier, so I don't know if you already covered if there's any link between statins and deficiency in PPI. And the last question, due to calcium deposits possibly in the carotid artery, has anyone noticed a higher incidence of dementia in PXE patients? Those are my three questions.
Well, let me pick up one of the questions that I may know a little bit of something.
Thank you.
And that's basically the statin issue. So there are some epidemiological data that even carriers of ABCC6 may have hyperlipidemias, hypercholesterolemia, specifically tied to a specific mutation, the R1141X stop codon mutation. There's a little bit controversy of that, but there is suggestion of, obviously, you want to keep the lipid profile under control anyway. In mouse studies, feeding mice with Lipitor lowers their cholesterol and also reduce the amount of calcium deposits, but how that relates into the human situation, that's, I don't think we have quite good handle at this point.
Thank you.
What were the other two questions again? Do you want to repeat them? Let's say the first question again.
Yes. Two cardiologists were in dispute. One told me take anticoagulants. The other one said, no, because you've got PXE. And so I stopped because I couldn't believe either of them. So I just decided not to take anymore. I took it for 5 days, and then the second person said, don't take it because you've got PXE. And I wondered if any link existed between anticoagulants, such as edoxaban and PXE. That was my second question.
Yeah. Well, let's do one at a time. We'll hear the second one in a second. I'm assuming that the concern was related to bleeding risk, and
That's right. Yeah.
I mean, I'll let Wayne address the issue of bleeding in the eye, because this has been studied both in diabetic retinopathy and I think in macular degeneration as well. But I think the risk here is probably being considered mostly for GI bleeding, and the risk there is increased by taking aspirin or non-steroidal anti-inflammatory medication. I think the decision really rests on what the indication for the anticoagulation is. I mean, if you've got atrial fibrillation and valvular heart disease and you're at high risk of stroke, then the risk of stroke is much greater than the risk of having a GI bleed, and you need to be on the anticoagulation. It really depends on what the what the indication for the anticoagulation was in the first place. Why was it suggested, or why was it prescribed?
It was because of atrial fibrillation.
Well, I think it's a risk benefit analysis.
Okay.
I think you need to go back to the cardiologist who suggested you not take it and find out specifically, why and what they were concerned about was. Wayne, do you want to address the issue?
Right, well, from the eye point of view, we usually ask a patient why they're taking, as Lionel said, and either an anticoagulant, strong anticoagulant, or even a baby aspirin. We ask them because they want to know, is the risk of bleeding increased? So first of all, we say if you're on an anticoagulant for a cardiovascular indication, then please continue it. I mean, we don't argue with the cardiologist. We say your sight's important, but your life is more important. But as Lionel said, some of our long-term studies with diabetic retinopathy, aspirin did not increase bleeding, and that was like 3,700 patients in the study. Of course, if you have a bleed and you're on an antiplatelet therapy, the bleed could be larger than it would have been had you not been on. But again, you're preserving your life. If you have atrial fibrillation, you need to be on some type of anticoagulant, I would assume. In fact, people who have mechanical heart valves, they really can't stop their anticoagulation. They stop their long-term anticoagulant. They put on heparin if they need a procedure. Then the heparin is stopped, they have their procedure, and they're started immediately. So we take that quite seriously. But if someone has arthritis or a headache and Tylenol works just as well, we say, please take Tylenol. Why would you take a blood thinner if you're having injections in your eye? By the way, when we do an injection, we go through an avascular part of the eye. And so we often do not stop anticoagulation. We usually don't. And even someone has cataract surgery, that's through the peripheral cornea and again, an avascular part of the eye. So these cataract surgeons do not generally stop anticoagulation.
Yeah, and we're not talking about antiplatelet anticoagulation here. I mean, she's talking about a
right. I know.
Anticoagulant. I think I would revisit the issue with your cardiologist, and I think it's especially where you have fibrillation.
I will.
This sort of raises a kind of broader issue, Wayne. So lots of people take aspirin, 81 milligrams, as a sort of prophylactic for cardiovascular incidents. And there was this recent recommendation, some advisory boards said that don't take. So how do you deal with that?
Well, the recommendation was if you have not had an event and you're not already taking it, not to start it. And the risk, of course, they were talking about was GI bleed. They weren't talking about PXE. So I think it's hard to, you have to believe the data. So people, if the risk of a GI bleed outweighs the benefit of a baby aspirin, then people should not take it. But interestingly, they said if you're already on it or you had an event, you should continue it. So, so I think you have to believe the data. It's interesting because a small aspirin, 81 milligrams, does block all of your platelets. But of course, you make new platelets every day and you replace all your platelets every 7 days. So, so you need to, continuously take aspirin if you're going to protect yourself against a cardiovascular event.
What was the other question, Hope?
It was to do with the carotid artery. I thought I heard mention of the carotid artery being one of the sort of arteries that could be affected by calcification due to PXE. And since I've always imagined that leads up into the brain, is there any link between a higher frequency of dementia in people with PXE compared with a normal population?
Yeah, I don't know specifically about epidemiologic studies, but there are well-documented cases of multi-infarct dementia where people have had small vessel disease. We're not dealing with the common carotid or the internal carotid, but more with the branches that run off from these, the smaller branches and the branches of the branches. And when these become blocked off, you get small infarcts or small areas where there's death of brain tissue, and there's a subset of dementia patients who actually have dementia due to multiple cerebral infarcts, multiple areas of brain tissue death, and that's not common, but that's the type of dementia that's most closely associated with PXE. But it's an uncommon complication.
Thank you.
My staff is texting me, registry, yes, because until everybody answers the questionnaires, we won't know the answers to these questions. We do know from the earlier studies that we did that in fact, about 5% of people with PXE reported stroke. We haven't done any study on dementia. Thank you.
Thank you very much.
Okay. What about fish oil? Is there a risk of increased retinal bleeding? And while you're at it, there's a bunch of other stuff in the chat about NSAIDs, aspirin, Plavix. Should we take them? Should we not? I generally, by the way, tell people you really need to talk to your physician and assess risk. If you're going to die and keep your sight, that's probably not a great trade-off. However, if you can take some alternative form, then you should. But I'll leave that to you guys to opine on.
Mm-hmm.
So Wayne, fish oil and retinal bleeding?
Well, I think we already covered that. Risk-benefit ratio. Again, listen to your internist. I agree with you. Fish oil, by the way, was tested in the AREDS2 formula and not shown to be beneficial. So it's not taken in macular degeneration patients to reduce their risk of bleeding. Whether it increases the risk, that I'm unaware of. We talked about the other platelet agents, antiplatelet agents, and blood thinners. Ask your cardiologist, ask your internist. You have to have a maestro, and we'll take care of the eyes.
Great.
I mean, most of the time when things like Plavix are prescribed, it's usually to prevent stenosis of or blockage of a stent after it's placed, and it's usually a temporary thing, and it sort of defeats the purpose of the stent if you don't protect it from clotting. So I think in situations like that, whether it's a carotid stent or a coronary stent, or a mesenteric artery stent or a renal artery stent, or wherever it's placed, there's a significant risk of clotting immediately, for the period of time after it's done, and the benefits outweigh the risks. So I think usually in that situation, we tell people, go ahead and do it. I mean, we certainly would never tell them not to do it after they've been prescribed it for a very valid indication. It's just, that's something where they have to really deal with, where dialogue between whoever's prescribed it and you or us, even if necessary, is helpful. But it as was mentioned earlier, it's risk versus benefit. That's how basically what all decisions in medicine boil down to.
Right, and so the chat is asking, so are NSAIDs contraindicated for the eye reason? And I think I've heard you say, Wayne, you have to really weigh the benefits and risks.
Right.
I think
we talk about relative contraindication and absolute contraindication. If you're taking it for a medical indication, then it's worth the risk-benefit ratio. If you're taking it, like we said, arthritis, headache, and Tylenol works as well, please take Tylenol.
Yeah. I mean, I think the risks. I mean, I think the risk with non-steroidal anti-inflammatories is really more gastric bleeding, and even then, the risk is not great. I mean, if somebody's got, I wouldn't take it for minor pains or for headaches, but if somebody's got crippling joint pain, they may need it. I mean, there may not be a better alternative. I guess they could take Celebrex. I mean, that's probably easier on the stomach. So there's always an alternative.
Anything else? All right. Well, I want to thank our experts. I'll get to the registry questions in a minute, but want to thank you guys and the experts throughout the day who shared with us. We're always grateful, and it's always really terrific that we have such consistency and the sense of you continuing to work with us and to show up for us in so many ways.
Thank you.
My pleasure. Great. Thank you.
Yeah,
Thanks for having us.
Yeah. Thank you.
Yeah.
Bye,
Thank
Sharon.
you. Bye. Okay, so registry questions. I am going to say that to the questions that were put into the chat. So yes, we do let you know every single time there's a new survey there. So someone said, well, I haven't answered much. I agree with you that you haven't answered much, but of the 1,000 people registered, only 600 have answered the question. So we have 400 people we're still kind of badgering to get in there and answer even the few questions we have. So we were reluctant to roll out more because for some people, if they go in there and see 4 questionnaires instead of 2, they get pretty freaked out and don't want to do it. We're trying to kind of keep everybody moving along at the same pace. So we are working as hard as we can to get those 400 who are registered who haven't answered the questionnaires to actually answer them. And then we will, in fact, be deploying some more. There probably will be a couple questionnaires in the next few weeks. You will hear about them multiple ways. You will get a message through the system itself. You'll get messages in chat, if you're in PXE chat, which is the online Google group. You'll get them on Facebook. You'll get them in the newsletter. We will send them to you every single way we possibly can. So we appreciate those of you who have registered and answered the questions. We even had a couple people here who'd rather pay the $25 than answer the questions, and so didn't register. I'm hoping you changed your mind by the end of today, because so many of the questions that you've asked, which are excellent questions, we just cannot answer because we don't have the data. And again, as we get to these trials that are going to be happening, we are not going to be able to take them to the FDA for the kind of scrutiny they need unless we have the answers to how does PXE progress, what do we measure to know whether or not it's slowing down. It's a slow disease. It's not like, a pediatric disease like Tay-Sachs, a child dies by the time they're 5. And so you can do a study because in a year or 2, they're completely debilitated. That's not true in PXE. And you all know that some years you have no change. And is it because of the drug you took, or is it because of just your body itself? Those are the kinds of things we have to really suss out. And so we're very grateful to you for sharing your clinical data. Anything else anybody needs to know before we close for today? What I'll do is open breakout rooms. This time I'm going to mix you up, not by geography, because you probably would like to see a few more faces. I'm leaving the software open and up until tomorrow evening, and so you can meet with whomever you want in here. You can hop rooms if you want. It's up to you. So anything else anybody needs to know or would like to know? Tomorrow you'll hear a lot about the research that's happening because all the researchers will be coming. Some of them the same as the ones that you saw today.